welcome to everyone joining us this afternoon. We're very pleased that you're able to come along. This afternoon's webinar is talking about common issues that might arise when supporting people with Huntington's disease in a care setting. So on the call this afternoon, we've got Eve and Rachel and Tiffany, who are all specialist advisors for the Huntington's Disease Association. And what the format of this afternoon is going to be is we're going to look at 4 case studies which highlight sort of common issues that you might come across when supporting people with HD. What we'd like to say is that we're going to talk about the case studies, and even Tiff and Rachel are going to give their ideas about them. But if you have anything you would like to add or any questions that you have, please put them in the chat or the Q&A, because these are very much sort of like we'd like a bit of collaboration on these. So if you have ideas, things that we haven't said that you think might be worth taking into consideration when we're discussing each case study, if you please just pop it in the chat, that would be great. So just before we start, we're just going to take a couple of minutes just to have a quick reminder about what Huntington's disease is, just to set the scene a little bit. You may probably already know that with Huntington's disease, we talk about there being a triad of problems. And what we mean by that is there's 3 groups of problems that people with Huntington's may get. So that there's physical problems, there's thinking problems, and there's problems around mood and behavior. And sometimes it can be quite difficult when there is an issue to unpick, is this a physical problem, or is it a thinking problem, or is it a mood problem? Just to give an example, just to illustrate what I mean, say you're supporting someone with HD and they stop eating. Potentially a physical explanation of that might be that there's a problem with their swallow, because obviously we know that people with Huntington's experience problems with swallowing. It could be potentially a problem with their thinking. So maybe that person's sitting down to a meal and they're struggling to initiate that task. They're struggling to get going on that task. So it might be nothing physical at all. It might be a thinking problem, a cognitive problem. Equally, maybe it could be something to do with that person's mood. So maybe it might be that person's mood's very low, and obviously we know that low moods can cause people's appetite to lessen. So it might be their mood that's causing them not want to eat. So that one problem, stopping eating, could potentially have a physical explanation, a thinking explanation, or a mood explanation. So that's why it's really useful to think of these 3 areas when we're trying to problem solve. And obviously, just to quickly remind about the physical problems that people have, if you just bear in mind, we know that people have problems with voluntary and involuntary movement, problems with speech, problems with swallowing, and we know that people also have problems around maintaining weight. So there's a lot of physical issues that people might have. So common thinking problems are things like struggling with multitasking, struggling with planning, thinking ahead, struggling with initiating tasks. And mood problems, people can have low mood, people can have anxiety. So that's just a very brief reminder of some of the issues that people with HD might encounter, which obviously have a bearing on some of the case studies that we're going to show you. This is just a very quick reminder of what's happening in someone's brain when they have Huntington's disease. So the brain on the left is the brain of someone without Huntington's, and the brain on the right is someone with Huntington's. And obviously you can see some quite obvious differences between the 2 brains. So the Huntington's disease brain, you can see it's smaller, so brain matter's been lost. You can see that it's gappy, and you can particularly see that there's areas that are quite atrophied. So if you look at the non-Huntington's brain, you'll see this grey area called the basal ganglia. If you look in the Huntington's brain, that area is really atrophied. You can hardly see it. And because of the damage in that area, that causes a lot of the symptoms that we see in Huntington's. So this is really just a reminder that the physical and the cognitive and the mood and behavior symptoms that we see in Huntington's disease are as a result of these types of changes in the brain. So that's just a little bit of a reminder about Huntington's. And now we're going to have a look at our first case study.
Well, that's me
So,
up.
Is it Eve? I think, is this you first? I think.
Me, I'm first. Yes. So our case study, we've based our case studies on sort of typical problems that we come across when supporting people with Huntington. So I'm sure this is something that's quite familiar with people. Stephen, who is a 56-year-old gentleman who was previously a mechanic, has recently come into a care home for respite. The home and staff are new to Stephen. Stephen is reluctant to change his clothes or consent to support with any personal care tasks. His clothes are stained and Stephen remains in his room and can become loud and swear at the staff who ask him if he wants help with any washing and dressing. As I say, this is something that conversations we have quite frequently. So obviously it's a new environment for Stephen, so that's a big change for him, and surrounded by people who he doesn't know, which obviously makes him uncomfortable as well. So we will share some thoughts on how to support Stephen with these tasks, giving Stephen time to settle in a new environment. It's a big change when you move from home into any other place to be looked after. It's loss of independence is a big thing to take on board. So it's ensuring that Stephen feels supported whilst being as independent as he can be. Routine is really important with people with Huntington's. It helps them feel familiar with the situation. So we always suggest things like diaries and whiteboards so that they can see the day is planned out. There's no surprises or anything that crops up that they're not anticipating. So that really helps them adjust to the fluid, the flow of the day, ensuring that communication is very clear. So the expectation of what's happening. I use lots of words, most of us do, when we're having conversations with people, and that can really get lost when you're working with people with Huntington's. They just need to keep sentences short and simple so that they can retain that information. With it being an unfamiliar environment, it may be that Stephen isn't familiar with the layout of the place, or that his belongings aren't there. So for a lot of people with Huntington's, if things are out of sight, they're not able to remember where their belongings might be. So leaving clean things out might help prompt Stephen to change his clothes and sort of lead him into the task of personal care. The same as just propping the bathroom door open. Trying to get Stephen familiar with certain staff, and that's a bit of a challenge when you're working in care, both in the community and in residential establishments. There's lots of people and lots of changes, but we all know that having personal care can be very undignified, and people are very nervous of that. So it's just ensuring that Stephen is comfortable with the people that are supporting him and talking him through the process. So it may be that he feels that the water might be too cold, or that somebody might come into his room. He's not got any privacy. So it's just talking through the task, reminding him that he can lock his door, that the water's the right temperature, and all those sorts of things. So trying to take some of the anxiety away of the what ifs that are involved in the task. People who have Huntington's disease are very easily distracted, and this is very difficult in a busy environment. But the alarm bells and lunch times and TVs and radios, all those sorts of things detract that person's attention from the task we're trying to achieve with them. So it's ensuring that anything that may distract that person is switched off or door shut or any of those sorts of things, so that they can completely focus on the task that we want them to be successful in. And the last snippet of helpful advice. So when we're working with people with Huntington's, we advise people that it takes about 7 seconds for somebody to process a sentence. So not only keeping your sentences quite short and simple, but allowing quite a long period of time for that information to be processed so that that person can fulfill that task to the best of their ability. I think that's all our points.
Yeah, and I think we've got a comment in the Q&A here saying that suggesting maybe a behaviour ABC assessment over a week or so, looking for triggers and times of day and which members of staff do better.
Yeah. There's a team approach. It's being collective, and it's a very good suggestion. Certain times of day might be better for different people. Some people aren't morning people. I feel their pain. So absolutely a good suggestion about finding out if there's a particular trigger or a particular person's got a certain approach that works well, and others can learn from that.
It just, sorry, if I'm just butting in, it's just reminding me of someone that I had contact with in a very similar situation, and he couldn't cope with all the, first thing in the morning when there's a lot going on and there's, sort of people kind of getting ready and there's breakfasts and there's a medication trolley going around and there's a lot of things going on, and he couldn't cope with then doing his personal care when there was all that happening, and he just wanted to be left alone, but he was quite happy to do it in the afternoon when things
later in the day when the day's a bit calmer.
So that very much fits with what you were saying. Sorry, Tiff, I interrupted you.
Yeah, just on what you've said there as well. I wonder, what was his routine at home as well. Actually, some people don't have a shower in the morning and might have trying to mimic that as best as possible in a different environment. And I know, Eve, you said that he used to be a mechanic. So is there something about bringing the familiarity of his, of perhaps the work he used to do, trying to do some activities with him in the home that help that kind of focus on those skills he had in his working life to help him feel more settled and more familiar, and that then in turn might help him to do some things like the personal care, which maybe he doesn't feel comfortable or doing in the home at that moment in time. So it's looking at the him as a
looking at the
person as well, isn't it?
Yeah, the person as a whole, isn't it? And it may be for this particular person that their idea of what's clean and presentable is slightly different to mine, because he's obviously always worked in an environment that's not been office based or those sorts of things.
Much more practical, yeah.
So going back to your point, Eve, as well about leaving the clothes out and about kind of orientation, I think if it's possible to involve him right from the start, where do you want us to put your things, so that he has some involvement in that, but also reminding him of, it's not just that one-off time. It's kind of, he might need to be prompted several times to remember where his things are. It might not just be a one-off. So we might have to keep working at it.
So this is Sam. And Tiff, I think you're reading out Sam.
Thank you. So Sam is 45. He used to work as a chef. He comes to the main room for his meals at the nursing home that he lives in, and will sometimes join in activities if he is encouraged and given enough preparation and notice. 6 months ago, Sam started coughing when eating one of his favourite foods, fried chicken with chips. He usually orders this online after his evening meal. The staff then deliver this to his room. A speech and language assessment have found that Sam's experiencing dysphagia and have recommended a soft and bite-sized diet. It has been explained to Sam that it is now not safe for him to eat his takeaway because he may choke. Sam seems to understand, nods, and when asked what might happen to him if he carries on eating his takeaways, he says, die. But the staff are not sure he fully understands. Sam has also slowly been losing weight over the last year, but is becoming less mobile and spending more time in his wheelchair. So, yes, I wonder what everyone's kind of initial thoughts are on this situation. Always, I think, really challenging for, of course, family members and carers if someone is losing weight and they're struggling to perhaps take as much nutrition as they need, but also, someone's enjoyment around food and things, and trying to get that balance right. So thinking a little bit about what might help here. Would it help if Sam needs to be engaging with food in different ways to keep up his passion, such as activities involving cooking? Considering he used to be a chef, would it help him to be involved in the preparation of his food now that we know it's likely to have to be changed a little bit with the consistency and texture? He may not enjoy that as much, considering we know he loves his fried chicken. So is there a way of him kind of being a part of that, of his, you know, relationship with food, which of course is now changing a little bit? Sam might struggle to retain some of the information that's given to him verbally, you know, quite a complex information to have to grasp and to understand your kind of changing needs and things. So do we need to look at a different way of approaching this? So might using pictures or a whiteboard or something similar for him to look at and remind him, help him to make decisions around eating that are safer for him. I guess another area is to consider is to ensure that Sam is aware of the dangers of eating at risk, and kind of be able to reiterate with these to him and ensure that he's able to retain this information. The care staff can involve all the relevant professionals. I think it's really important that, you know, care homes are not dealing with this on their own, and that they involve everybody to get everybody's kind of expert area, you know, areas, you know, and get their insight, including family if they're available, and you know, they might have had discussions around situations like this previously, and if Sam of course has capacity, just making sure that that's documented and everything, so the home can say, we've had these conversations, you know, we've made sure that Sam understands he's eating at risk, but that his enjoyment and love for the food is very, very important to him. And then obviously revisiting this over time in case capacity changes and things like that. Of course, we touched upon weight loss, and considering Sam's less mobile now but still losing weight, I think, you know, obviously getting a dietitian involved to try and minimize any further weight loss could help. And also it may be that if he's eating food later on in the evening, is he not eating enough during the day? And so would a dietitian be able to help, you know, add some extra calories here and there, make things a bit more delicious for him to try and avoid further weight loss, because we know that can sometimes exacerbate symptoms of Huntington's as well. So trying to make sure he doesn't lose any more weight would be really, really helpful here.
There's a comment here, Tiff, which sort of just follows on from what you've just said. There's someone saying about presentations so important, and mention about food molds to make the food look more appetizing.
Yeah, that's a really good point, especially if you think of his history, you know, his work history of having been a chef, you know, and they say you eat with your eyes, don't they? And I guess if things have suddenly been modified and look very different to what you've been familiar with, then that's another big change, isn't it? And going back to like familiarity and routine and consistency, that's a really, really good point, you know, making it look as lovely as it can possibly.
It's difficult, isn't it? Because food for a lot of people who are not well is a real pleasure, isn't it? And enjoyment, and you know, lots of positives come from being sociable around food and those sorts of things. So it's ensuring that he's still got those opportunities, and as you say, experimenting with different foods, and just maybe getting a bit more involved. He might find other items that he'll enjoy as much.
Yeah,
I actually wonder if there's a way of modifying his chicken recipe to kind of still have that taste, but not the consistency, you know.
Yeah, that's a really good, fry it but without the bones. You know, you could make something that really resembles that, and it's got all the deliciousness. Yeah, it's making me hungry.
And it's important to remember that for some people, they do eat at risk, as much as that must be really scary for the staff that are supporting that person. You know, again, going back to food being absolute pleasure. If somebody took my cake away, they'd be war. You know, and sometimes we make decisions and support people with those decisions that make us feel really uncomfortable.
Yeah.
But it's important that we support people with their wishes as and what they are.
Yeah, and if that has been clearly documented, you know, that Sam doesn't want to peg feed or anything, then it is about managing that as best as possible, isn't it? And just trying to keep his weight up and all work together as well, and share the challenges that this presents as well between everybody involved.
Really important to inform new staff as well, if that's an issue, because obviously if new people are coming in, they're not aware of this, it can be quite a worry. So it's about communication, isn't it? Everybody working together.
And we've just got a comment here saying, would a reminder about the previous conversations around the risk of eating chicken help at the time the person is ordering? Sometimes impulsivity acts against the capacity. So it's about when you're having that conversation. It seems like a really good point to make about when, you know, that you're having that reminder at the point where that's happening.
It's about knowing the individual, isn't it? And it's maybe at that point that they're ordering that you could encourage them to look at alternatives and a gentle reminder that actually that's something you struggle to eat now, you know, but how about chicken burger or an alternative that may be similar but with less risk for that individual.
Yeah, I guess it's giving them the choices, isn't it? As we say, you know, reducing the choice to kind of maximize their choices, essentially.
Listen, some people just do things out of routine. You know, it may be that for this individual, yes, that's their favourite food, but they've not got the ability to sort of think about other options. That's just automatically been their go-to. So when you're sort of sitting, looking at menus and things, actually bringing in alternatives that they may be able to consider and recognise through sort of pictures and menus rather than relying on their long-term memory, which may not be so easy for them.
So this is Julie, and I think, Rachel, you're going to tell us about Julie.
Yeah, this is me. So this one's about smoking, which I'm sure, you know, lots of care homes probably come across issues like this regularly. So let's have a look at Julie. So Julie's 52 years old and she moved into a residential home 6 months ago. Her involuntary movements are aggressive, which makes holding objects difficult. Julie spends hundreds of pounds on cigarettes and is constantly lighting up throughout the day. Her movements mean she drops the cigarettes once lit, occasionally burning herself in the process. Julie likes to keep a large stock of cigarettes and becomes upset and agitated if her supply reduces. She asks staff to accompany her to buy more, as she is unsafe to go to the shops independently. Staff are not always available when she wants to go, and on occasions she has left the care home unaccompanied. Julie's family are keen that she retains the ability to smoke, as she relies on others for everything else. So I'm sure if you're involved in caring for people with Huntington's, this might be familiar. So just a few thoughts, and again, if anybody's got any comments or ideas or suggestions before we move on, I've got a few ideas here, but if you want to put them in the chat, then we can consider those as well. But before we look at the solutions, there's this, you know, there's lots to think about here. Julie's lost her independence, and she's got little control over her environment now that she's moved into the home. And waiting can be really difficult for people with Huntington, so that's something to bear in mind when we think about the solutions. Is her smoking a perseverative kind of behaviour? Is it something that she's sort of fixed and stuck on and it's really hard for her to actually break? I think we mentioned that earlier when we were talking about the chicken. You know, it might be that it's just her go-to, it's just her kind of day-to-day thing, and breaking that cycle is really quite difficult. Smoking is one of the only things that she has left. So you know, the fact that she's in a care home environment, there's very little else unless other things can be explored for her to do. So shall we have a look at some of the solutions? Okay, so how might we be able to help Julie? So does she need more time on a one-to-one basis for activities, to go out? You know, if she's wanting to go out to buy the cigarettes, perhaps she likes being outside. Perhaps there's other activities she might want to do, but she hasn't really had the opportunity to do that. And that moves very nicely into the next one, which is exploring other things that might be meaningful to her and might give her more structure to her day. At the moment, it sounds like her life kind of revolves around smoking, and that's kind of what drives her behavior. So it's looking to see, what was life like before she moved into the residential home, and is there anything else that they could look at to sort of appeal to her values and her sort of roles in life? Are there any what role does she have within her own family? Is there anything that they could do around that? Maybe building in shopping trips, but with the proviso that there needs to be a contingency plan if the staff can't actually do a shopping trip for some reason. We all know that sometimes homes can be short-staffed at the last minute, and it's not always possible to put in place what the person wants to do. So but that might help her to know that she's got a constant supply and that it's not going to go down to a number that she's not happy with. And again, that moves nicely into the next one, which is kind of reassurance around her cigarette supply. How much does she have left? Could there be an agreement on what her sort of minimum number of packets would be, so that if it hits that minimum number, there definitely needs to be a plan to get her kind of more purchased. I've been sort of looking at the chat very briefly here, and I can see that somebody's already mentioned smoking apron. Yes, that's definitely something that could be considered, so that even when she is smoking, if she's dropping it on herself, it will prevent her clothes from becoming damaged and from burning herself as well, because obviously there's the risk of burning her skin and other people potentially if she's around other people. Is there any and smoking aids as well? Sometimes you can buy particular aids that actually hold the cigarette for you, so that if you have got very violent, aggressive career, then you don't actually have to hold the cigarette in your hand. You can just sort of have it in a stand, and that sort of prevents the risk of you dropping it. Is a medication review needed? So if the person's involved with like a specialist clinic, or they have a multidisciplinary team, maybe we need to think about medication changes. Is there anything that is going to help? Because it's quite tiring, having involuntary movements, particularly when they're aggressive. It has a real impact on somebody. So it could be that medication might be needed to help this person to sort of control that a little bit, but it's not always the answer, unfortunately. Encourage her to have rests with sufficient support. And then if it really is becoming a problem where she's leaving the home and people aren't aware, she's putting herself in danger, then we might have to look at something like liberty protection safeguards, which is formerly known as DOLS, because if she's going out and she has a fall or whatever, the risks are huge. So yeah, I think there's been quite a few comments in the chat.
I don't think you can see, Rachel, a couple of people have mentioned about vaping.
Yes, that is another option, isn't it? Definitely. It would prevent the problem of the burning. And I don't know how expensive vaping is, to be honest, but it might be a bit cheaper for her as well, but definitely less risky, I would have thought. So yeah, definitely one to think about. And
I can see someone's mentioned about, I think what you mentioned about smoking tubes, the thing where you might have a tube going into a cigarette that's sitting in an ashtray. And someone, and also the same person's mentioned about establishing boundaries. And I think that's again that idea of routine and familiarity and knowing. So I think the suggestion is about e.g. a cigarette every hour, or you go shopping for cigarettes every Monday, Wednesday, and Friday. That sort of thing. So that person knows what's happening around that, and hopefully there could be some reassurance in that there's always going to be cigarettes, because they know that
absolutely,
the next day I'll be going out to get some more, so they know that that's set up.
Yeah.
I think there was a couple more comments there.
Yeah, I think there was one about having like a backup of cigarettes in case she runs out.
Like
So
a
that
loan.
the home can loan. So you minimize, of course, just the withdrawals and anxiety and everything that would bring in that moment. And then I guess you make it clear where we go on Wednesday and we'll restock the cigarettes and we'll put those back in our like emergency cigarette kitty. A good idea, isn't it? Because if you're going to get angry and frustrated when it's not there, the only way really to manage that is to satisfy the nicotine craving, isn't it? Because that also interacting with HD must be quite, must be difficult perhaps to pinpoint where the irritation is coming from, but knowing that you want your cigarette and not being able to have that and having to wait must be, really hard. So that sounds like a good idea too.
Yeah, I don't think, see, there's someone commenting there says, massive problem for 2 of my HD patients keeping cigarettes in their mouth due to dexterity, saliva, and involuntary movements, meaning the cigarettes breaking at the filter tip before they've smoked half of it, therefore needing to smoke more. And this person saying they've tried cigarette holders, and any other ideas around that?
I think the one, Eve, that you've recommended, is that the one where it's on a stand and you don't actually have to hold it?
So it's a very weighted kind of ashtray, and the cigarette goes into the ashtray, and then the person who's smoking holds a tube. So they're not actually holding the cigarette or the ashtray. That's obviously on the floor or somewhere stable. And then they just have to hold on to the tube. So I know some people that have used it successfully. I know some people who have absolutely hated it, but it just makes the action of smoking a lot safer.
Yeah.
And I think, Rachel, you mentioned this about someone else's comment about the suggestion about the home keepers to a supply of cigarettes to loan to when staff are not available, but the next time she goes out she can replace the loan.
Yeah, definitely. And I did wonder whether we've talked about whiteboards for somebody else in one of the other case studies, but maybe if she had like a little timetable in her room that shows her when she's going out for a cigarettes, and that can be almost like a reminder, Monday, Wednesday, Friday, the days that we go out. If in the meantime you run out, we've got supply, so you don't need to worry, kind of thing. They're all worth trying, aren't they? There's no guarantees that they'll work, but different options that people can think about and try, definitely.
And I'm just noticing there you've put a link to one of the smoking aids. That's the one with the tube into the ashtray, isn't it? Yeah. So if people wanted to, was something people were interested in, they could follow that link there.
Obviously something that someone like an occupational therapist or somebody would just have to put an opinion in. It's not.
Yes, for that particular person, because I suppose any bit of equipment always comes with the proviso that not all pieces of equipment suit everybody, and it is, it should be an assessment around that, from an occupational therapist to make sure that particular bit of equipment is suitable for that particular person.
And the fire service are very helpful, obviously not with smoking aids and things, but for people who are obviously in the community where they're home alone and those sorts of things, they can put in sort of express fire alarms, which go straight through to the fire service, and fire blankets and covers for their sofa, and making it as safe as, as low risk as it possibly can be. So they're very helpful in that area where I am.
And this, the last of the 4 case studies, this is Sheena and Rachel. Are you reading Sheena out? Or is it
me? So last but not least is Sheena. So Sheena's lived in a care home for a year now. She is 55 years old. When she first arrived, she was keen to join the activities that the home put on. However, over the past few months, she has started to decline coming along to the lounge to participate in any of the group sessions, and tends to spend most of her time in her room. In the past, Sheena has had a wide range of interests, including hill walking. So, yes, this is something we hear quite a lot, isn't it? Often with people just not taking perhaps an interest in the same things they used to, and sometimes withdrawing from these things. So
there's a lot of things to sort of consider, isn't there? Sometimes a group activity can be noisy in a busy environment. It may be that for this particular person that's too much for her now. It may be that her illness has moved on, and actually she just feels she needs to be doing more one-to-one things, a bit quieter, you know, things that will capture her interest. And you've got to look at the lady's age, and I know she's kind of a little bit past her when we think about menopause and those sorts of things, but you know, maybe there are other contributing factors that may be making her withdraw and spend some time by herself.
One thing we didn't say was that she might be feeling more tired, actually. And, you know, it's we all know that Huntington's can make people tired, you know, the movements, you know, your body's, if you do have involuntary movements, your body's having to work harder, isn't it? And so she may just be getting very tired. That's not something I think that we've put here, but I'll kick off, Eve. So maybe she needs to do one-to-one activities rather than the group activities. Like we just said, perhaps being in a big group of people is too much for her. Perhaps it's too overwhelming and she can't sort of manage all the interactions and you know, follow the conversation that is being had. So perhaps maybe looking at a one-to-one type activity with a member of staff, or even with a resident, if that seems appropriate. So that's one thing.
It may be that something's happened, and the nature of a busy environment, it may be that the staff involved haven't seen something that's happened and there's been a falling out or an upset. You know, try and have a conversation with Sheena about, you know, why she doesn't want to come to activities anymore. You know, is she uncomfortable in a particular seat? You know, is she uncomfortable sat next to a certain person? And just trying to talk it through with Sheena and hopefully introduce her back into the group so that she can enjoy socialising again.
Yeah, and so someone just put a comment here. Just the sessions may be boring to her, and obviously it's saying it's difficult in care homes to meet everyone's needs in terms of interests.
Or it may be that it moves too fast. So going back to the nature of Huntington's with that processing that takes about 7 seconds. If you're playing something like bingo and you're moving at quite a fast pace, she may not be able to keep up with that and feel frustrated about the activity.
Yeah, definitely. That could be the same for other games, couldn't it? Absolutely. Perhaps she just needs a little bit more help. So even if it was a bingo game, maybe somebody could help her by perhaps identifying the numbers, and she just has to sort of put the dobber or the counter or whatever it is on the number, so she can still participate, but you just have to sort of adapt it slightly so that she can still be involved if she wants to. Maybe simplify things, break it down into stages, maybe more kind of visual instructions, so using pictures or illustrations, and yeah, joint participation to help her initiate the tasks. So get her sort of to start things, but sort of prompt her and guide her and just give her that reassurance and that encouragement.
I think I'm going to merge the last two together. So it's trying to personalize things, and that's very difficult in a busy environment. But, you know, if you've got the opportunity to do some one-to-one work, you know, taking Sheena out of the home, she obviously previously enjoyed being in the countryside and walking and those sorts of things, you know, encouraging her, if at all possible, to sort of revisit those things. But I think a lot of our families and the people we work with, you know, I've yet to meet anyone who doesn't have a really interesting history of some sort, and to look at their photos and sort of their past life and putting something together for them, it can be really rewarding and something that individual can enjoy and continue to add to, just sort of a scrapbook or a history of the things that I've enjoyed in the past. Something like that's a really valuable piece of work for new staff coming in and out, so that they've got a conversation piece, and it's something that can keep being added to.
It's probably worth mentioning, and we've got it's at the end of the presentation, that something called Green Opportunities. Had a little while ago had a webinar from a lady called Kathy Lyon, and Kathy talked about Green Opportunities, which is essentially looking at making the most of what people can do and what they are interested in, and how you make the most of that to maximise quality of life and people's feelings of enjoying life, and that their interests are being catered to. So that's on our YouTube channel. So that's in reference to this particular case study. That would be a really good one to watch.
I think it's important to remember that the small things for all of us mean an awful lot, you know, and we try and think of elaborate, wonderful, joyous things to do with people, where actually just sitting and having a cup of tea in the garden and having just that quiet time could be just what that individual wants and needs at that point in time, that it doesn't need to be elaborate.
Yeah, I think that's it. Sorry, Rachel, do you want to go?
I was going to say, it could be, I don't know if anybody's ever heard that radio program. I think is it Claire Boulding that does Ramblings on Radio 4, where she goes on walks and she talks about them. You know, even if it was something like that, I don't know, that kind of would consider her interest of hill walking, you know, little things like that might
evoking nature into the home, and getting that, and it's sensory, you know. I think sensory things are so important, aren't they? And they can really give that kind of, really nourish people, and often those things are perhaps lacking sometimes in care homes, depending, you know, that variety of sensory kind of benefits. So yeah, that would be, I think that'd be really lovely for her.
This is really just a few general points, really, just to make sure that these sort of things override a lot of all the case studies, that this is something we should always be sort of at the back of our minds, knowing that sometimes messages aren't getting through because of what's happening, the organic changes that are happening in the brain. So it's always worth thinking, if people's behavior changes or mood changes, or that they're presenting as anxious or angry or whatever it might be, it is to do a basic check in terms of the basic needs being met. Are they hungry? Are they thirsty? Are they too hot or too cold? Are they sleeping okay? Are they fatigued? Is there pain there? Because what we do know is that sometimes when there are these problems, someone with Huntington's may not be able to communicate that to you. So they can be often very reliant on the people around them anticipating those needs or guessing what the problem might be. So going back to kind of basics is always something that's worth doing. There's just a mention there about what I just mentioned before about the Green Opportunities webinar that we did a little while ago about quality of life. It's if you're looking for it, it's down as quality of life, and it's Kathy Lyon, but you'll find it on our YouTube channel, and that's very much about taking small things and extending them into bigger and more prolonged activities for people. The other thing that's always worth mentioning is about an MDT approach. And I think sometimes, and I know we hear this from the contact that we have as advisors with staff who are working in care homes, that often they can feel quite isolated. And I think it's always important to remember that there are people outside of the home who can help. And if there's an issue or a problem with someone, we should be taking the MDT approach, and it's about bringing those people, you know, with the specialist skills, the dietitian or the occupational therapist, referring to them and bringing them into the home and including them in the problem solving. Other things worth mentioning are our website. So there's lots of resources on there, and there's a professionals area on our website. So where there's booklets and leaflets to download, which have more in-depth information. So it's worth having a good route round on the website. And also, I mentioned before about our YouTube channel. We've got lots of our previous webinars are on there and all sorts of different topics. So again, if you're looking for a bit more depth on any particular topic, it's worth having a look at that. And the other thing just to mention is our ongoing program of webinars. We've got another couple of webinars coming up in the start of October, aimed at people who are working in care homes. So the next one we've got coming up is about the Huntington's Disease Association Quality Assured program. So if you want to find out what that is, We've got a webinar in a couple of weeks' time coming up about that. And the other webinar we've got coming up, which is a particular interest, is about continuing healthcare assessments and about what the role of people working in care homes is in terms of collating information to facilitate successful continuing healthcare assessments. So we hope those would be of interest to you as well. If you suddenly have an idea of something you'd really like to see covered, you could email our head office, which is info@hda.org.uk, if there's topics you would like to see covered, because we really like to make what we do as relevant as possible to yourselves, to the people who are working supporting people with Huntington's. So yeah, so thank you very much for everyone coming, and thanks very much for coming this afternoon.